Hello, everyone, and welcome to the webinar, Community-Based Leadership and Capacity Building Interventions for the Prevention of Sexually Transmitted and Bloodborne Infections and Related Stigma. My name is Rachel McLean, and I will be your webinar moderator today. So before I hand it over to our presenters, I just have a few housekeeping items to go over. So this webinar is being offered by the Canadian Public Health Association as part of a webinar series that we'll be hosting over the next several months focused on the reduction of stigma associated with sexually transmitted and bloodborne infections, or STBBIs. So more information on this webinar series can be found on CPHA's website, and you can also look at the link provided on your screen. And you can also connect with me if you'd like further information on the webinar series. I will be providing my email address at the end of today's session. So hopefully everyone can hear me through either a headset or the speakers on your computer. Due to the large number of participants today, we've disabled everyone's microphone. While we'll certainly have some time at the end of the session for questions and answers from our presenters, we simply ask that you use the chat box to the right of your screen to pose your questions to today's presenters. During today's session, the presenters will be discussing a case scenario. You can download and review the case on the bottom right of your screen. You'll see there are two documents uploaded there, so you can download those and review throughout the session today. And I believe the presenters will also be providing a few minutes for a review of the case scenario prior to diving into some discussion questions. And then lastly, before we begin, just a quick note that today's session will be recorded, and we'll be making it available on CPHA's YouTube channel in the coming weeks. So today we are going to hear from Yoshith Pereira, Dawn Scarlett, Matt Conti, and Sarah White from the Peel HIV/AIDS Network. I'm going to provide you with a brief bio for each of our presenters and then hand it over to them. Yoshith holds a master's degree in public health from the University of Western Ontario and a clinical diploma in medicine. Advocating for equity and social justice, he uses traditional and virtual platforms to mobilize social change. With research interests in communications and leadership, his work in the use of digital technologies for population health and health equity gains was published with the Journal of Public Health Policy recently. His recent contributions in public relations earned him the 2016 Publicist of the Year Award by District 86 Toastmasters. Dawn, who joined the Peel HIV/AIDS Network in 2007, has worked providing direct service to people living with HIV/AIDS in the region of Peel. Dawn was the previous support services coordinator for the AIDS Network in Hamilton. Dawn has been employed in various areas of social service. She has worked in providing emergency shelter, operated food banks, worked as a child protection worker, and she has worked in developmental services. Dawn has been involved in chairing a citizen advisory committee on violence against women while working with the community to advocate for the needs of folks who are marginalized by both systems and policies. She has worked with youth in helping to find their voice on a variety of issues as well. Her work in establishing best practice guidelines for frontline workers in the AIDS service organization sector and supporting community development work with clinicians in the Greater Toronto Area speaks to her passion as an agent of change. Our next presenter, Matt, holds a master's degree from Carleton University in Women and Gender Studies, and his thesis research explored the complex liminalities that fat, femme, and or racialized queer folks face while navigating online queer social networking spaces, such as Grindr, Hornet, and Scruff. Matt has previously worked as a teaching assistant for the Department of Women and Gender Studies and Sexual Diversity Studies at Carleton University and the University of Toronto. And then our last presenter, Sarah, is currently in the process of completing her final year of the social work program at York University with a minor in gender and women's studies, and is dedicated to continued learning in the field. She has shared and lived experience with the 2S LGBTQ+ community, and she has had additional school and volunteer experience in the areas of mental health, homelessness, substance use, developmental disabilities, and domestic violence. So with that, I'm going to hand it over to our four presenters from Peel HIV/AIDS Network.
Hi, folks. I hope everyone can hear us loud and clear. So my name is Yoshi, and I'll start us off today. So the title of our presentation today is Do You Know Your Communities? Community-based interventions or community-based leadership and capacity building interventions for the prevention of STBBIs or sexually transmitted bloodborne infections and related stigma. So just to start us off, none of the presenters today have any conflicts to declare. Just so everyone's familiar with our work is guided by a person-centered approach, whereby the needs and wants of our clients are prioritized and used as a guide for the care we provide. We also work from the perspective of cultural humility, in that we refrain from making assumptions and we ask for more details from our clients in regards to their lived experiences. In terms of our funding, Peel HIV/AIDS Network receives funding from the Ministry of Health and Long-Term Care, and we also receive funding for our programs from the Public Health Agency of Canada and the region of Peel. So we'd like to start with a land acknowledgement based on where we are at right now, which is Peel region. And it is important to note that we are speaking about Indigenous folks at this point without speaking on behalf of Indigenous folks. We would like to acknowledge that we are gathering here, that is the four of us, on the treaty territory of the Mississaugas of the Credit First Nation, and before them, the traditional territory of the Haudenosaunee, Huron, and Wendat. We also recognize the contributions of Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening these communities in particular, and our province and country as a whole. The land acknowledgement is one of the many activities our organization takes part or participates in as part of the Truth and Reconciliation Commission's calls to action. A quick overview of our agenda today. So we're going to give you a brief background of our organization, Peel HIV/AIDS Network, and then run through the learning objectives. We'll then dive into a little bit of an upstream-downstream story, and going quite a little bit deeper into talking about our community-based interventions. We have a case that, as Rachel mentioned, can be downloaded at the bottom right. We'll give you folks a few minutes to sort of review that and then jump into some discussion questions. We hope to have as much time as possible for a Q&A. Just before we begin, just to note about language, we will be utilizing language such as gay, queer, and trans as umbrella terms, and not all folks are comfortable with that language. We acknowledge that, but these are the umbrella terms that we will be using for Two-Spirit and LGBTQ+ communities throughout our presentation today. So I'm going to hand off to Dawn, who's going to take on the rest of the few slides.
Okay, thank you, Yoshi. So I have the pleasure of introducing our organization to you. So we're the Peel HIV/AIDS Network. So we were granted charity status in 1993, and we were lucky that we were able to be formed based on the needs of the community, and we're located in the region of Peel. Our location, we serve a diverse community. Over 51.5% of our populations are newcomers. We focus on prevention, treatment, and care for people affected and infected by HIV, and they're a priority population. Our model of service is a treatment and care cascade, and we do prevention work in terms of individuals who use substance, harm reduction, and sexual diverse individual. We also focus on support and care for individuals who are HIV positive, and to connect to healthcare and ensure that individuals are not lost to care. And we come from an integrative model. As a service provider, we're located in the suburbs. So we're not out in a big center, and geographically, we have a very large area that we serve. So we disseminate information on sexual health, as I mentioned before, harm reduction, and we promote community education as well as health promotion and client support. So we work and focus on 2S LGBTQ plus issues and not just HIV. And here at FAN, we have, which is Peel HIV AIDS Network, we work from the lens of anti-oppressive, and we recognize that 2S LGBT communities are both systematically mistreated and disproportionately affected by HIV. In doing anti-oppression work, we are actively working to create awareness and counter oppression based on gender identity and sexuality. In determining people who are contracting HIV, it's all related, and it's the intersection. So sometimes we're finding that people who are affected with HIV or impacted by HIV, they're expressing other social issues in terms of depression, social isolation, poor self-image due to oppression, and this will inform the kind of sexual interaction and decisions that they will make. When we're exploring the issue of the 2S LGBTQ issues, it will help us better understand the context that many people who are HIV positive, it's a syndemic. So we come from a syndemic lens in looking at it. So just to go back and just to give you an idea for a learning objective. So our objectives is to describe the historical content of syndemics with regard to STBBIs and the relation to stigma in Canada, specifically for queer and racialized communities. List a number of community-based leadership and capacity building intervention that support folks most at risk of contracting HIV and other STBBIs. And we'll be discussing strategies for the integration of community-based intervention in a primary care in order to strengthen clients' confidence in navigating the health system. So to give you an overview of the syndemics, it's two or more affliction interacting synergistically, contributing to excess burden of disease in a population. So vulnerability to HIV among racialized 2S LGBTQ plus community is increased as structural, social, and biological factors interact in the context of social marginalization. So I have the first poll question, and the question is, do you know the AIDS service organization in your geographic region? I'll give you a chance to respond.
So it's fantastic. I think about majority of the folks here today are aware of their AIDS service organizations. I think we have 32 votes for yes, and we have folks from other ASOs joining as well, as I can see on the chat box. So brilliant.
Great. So my name is Matt. I'm just going to be taking over now from Dawn. I am the 2S LGBTQ plus training and capacity building coordinator here at FAN. And so I just want to present a parable that I'd imagine many folks with a public health background may be familiar with. But in this parable, there is a man who notices a person caught in a river current. And when the man goes down to get the person who is drowning in the current, he notices that he's only drawn to the rescue of more drowning people in the current. And as he goes to continue to save these people that he finds drowning, eventually he realizes that he is best off to walk upstream to investigate why so many people are falling in the river to begin with, rather than trying to save folks when they are already downstream. And as great as this parable is, I think because we are here today talking about 2S LGBTQ+ communities, it would be great to kind of queer this upstream-downstream parable with something a little more gay. And so I want you folks to imagine that a brand new gay bar has just opened up in the region that you're at. During one of the first drag show nights, the head drag queen notices that two of the performers' makeup keeps running off their face and ruining their foundation and eyeshadow. Alarmed, the head drag queen goes over to the workroom to see that there are more drag queens with running makeup. Lipstick is smeared down to the queen's chins, oil is glistening all over their foreheads, and their foundation and eyeliner is dripping all over their cheeks. In a panic, the head drag queen begins to frantically search for tissues, towels, blotting pads, anything that can be used to wipe the running makeup off the drag queen's faces. As she does this, however, she notices that this is only temporarily delaying more sweat from coming back out to ruin the makeup, and she knows that the makeup will certainly never make it through a 5-minute power performance of Diana Ross's I'm Coming Out. After trying to save as many drag queens' makeup as she possibly could, the head drag queen noticed something very interesting while investigating the workroom. None of the hired drag queens seem to own makeup primer. You know, the base that you put on your face before foundation to allow your makeup to not only apply smoothly, but last for long periods of time. That's it, the head drag queen proclaimed in her extravagant voice. The solution is not to run around with a towel wiping up the makeup, but rather we need to prevent that makeup from running in the first place. So this revised upstream-downstream story that I just presented highlights an important tension between public health's protection mandates to respond to emergencies, so that is in the parable, the wiping and the fixing of the makeup with a tissue, right? And its prevention and promotion mandates, so that is stopping the makeup from running in the first place, or to use the original analogy, moving upstream in the way we approach healthcare. Evidence is mounting that an approach to healthcare that fully addresses people's access to the determinants of health will benefit everyone. Here at the PL/HIV/AIDS Network, we call for a collective upstream approach, or rather an approach that uses the makeup primer that focuses on building and sustaining societal conditions that work to reduce health disparities. The 2S LGBTQ+ training and capacity building initiatives offered at FAN allow service providers to begin critically thinking about a fundamental question in their work. That is, how can we develop a habit of looking upstream, that is, at the structural determinants in the ways we listen, in the ways we decide what to speak about, in the ways we schedule our time and other resources, and the ways we set priorities for our local, regional, and provincial organizations. And so one way that we believe we can start to move that we can begin to move upstream or to start looking at the makeup primer is through community-based interventions. Now, community-based interventions work to center the lived experiences of specific communities, right, or specific cohorts of populations with the mutual goal of improving their overall health outcomes. Moreover, community-based interventions, or CBIs, as I move forward, focus on putting the community first and building their capacity to create systemic level changes. For example, if we consider HIV infections, it is clear that we must address the ways that structural drivers, such as racism and anti-gay, queer, trans stigma, inform these rates of infection. So in today's webinar, we'll provide a brief overview of 4 community-based interventions that we offer here at the PL/HIV/AIDS Network. And so these 4 are Totally Outright, Gender Journeys, Young Black Women's Project, and our training and capacity building initiatives for service providers. So the community-based interventions that I've just listed work to develop and deliver population-specific, cohort-based, peer-led, prevention-based initiatives that aim to increase participant knowledge and health-seeking behaviors related to HIV, HCV, or STBBIs. These courses build the knowledge and skills necessary to promote prevention-related behavior change and foster resiliency among priority populations. And importantly, upon completion of these programs, graduates are then often encouraged to become advisors, trainers for future programs, and to take on a bit more of a leadership role through these prevention initiatives where possible. The ultimate goal of the community-based interventions that we have here at FAN are used to increase the capacity of participants to prevent new STBBIs and to improve overall health outcomes. When I use the language capacity here, what I'm referring to is the participant's decision-making ability and self-confidence. This type of capacity increase can help participants navigate the healthcare system with the tools they need to combat stigma and discrimination as it pertains to STBBIs. So the first community-based intervention I briefly want to speak to, being aware of time here, is Totally Outright. And so Totally Outright is an evidence-based HIV, HCV, STBBI prevention intervention for young queer men 29 and under. This program was developed by the Community-Based Research Center for Gay Men's Health. We have delivered this program once a year for the last 4 years at FAN, and we continue to revise the content to be reflective of the current social and political climate that we're in. And if I can make a shameless plug here, we do have a Totally Outright event coming up, and it will be taking place on the weekend of February 2nd and 3rd, 2019 at Humber North College at their LGBTQ+ Resource Center. To apply for this program and all other information related to this program, I encourage participants to visit www.totallyoutright.org. The next community-based intervention that I'm going to speak to briefly speak to is Gender Journeys. Similar to Totally Outright, this project was adapted for trans and gender non-binary folks and those who are exploring their gender, hence Gender Journey, using curriculum that has been developed by Rainbow Health Ontario. This program provides trans and non-binary folks in Peel with a safer space to form meaningful connections to their communities. And with that said, this does lead me to my next poll question that I want to ask. Okay. And that poll question being, are you able to distinguish the difference between the terms cisgender and transgender? Okay, great. So it seems like about 82% of folks listening in on this webinar can distinguish, which is fantastic. But just to help those folks who perhaps are still in their learning phase. So for folks who are still learning, just a bit of help with understanding the distinction. So trans is kind of an umbrella term that we would use to describe persons whose gender identity and or expression differs from the sex that they were assigned at birth. And cisgender, or cis for short, describes a person whose gender identity aligns with the sex they were assigned at birth. And so I can use myself as an example to help make that slightly clearer. I was assigned M by my doctor at birth, and I do feel comfortable and affirmed with the identity man, and so I am cisgender. So great, yeah. Okay. The last CBI or community-based intervention that I want to speak to is the training and capacity building initiatives that we partake in here at FAN. So the Peel HIV/AIDS Network offers a variety of different workshops and training programs related to 2S LGBTQ+ inclusion and capacity building in Peel region, of course keeping intersectionality at the core of all of the work we do. Our training programs operate through an anti-oppressive and anti-racist framework, and our training initiatives were developed by members of 2S LGBTQ+ communities and also reviewed by members of the community. The workshops that we do here aim to familiarize participants and service organizations with some of the knowledges and skills that would be needed to begin fostering 2S LGBTQ+ inclusive cultures within their respective organizations. The 2S LGBTQ+ team here at FAN is made up of diverse members from the 2S LGBTQ+ community. Our facilitators here offer a breadth of expert knowledge that is rooted in lived experiences concerning 2S LGBTQ+ oppression, discrimination, and resilience on a local, national, and transnational level. Importantly, I want to state that our trainings operate through a 4S bias model that values lived and shared knowledges from 2S LGBTQ+ folks. In addition, and importantly to FAN, we do utilize expert peer facilitators from diverse 2S LGBTQ+ communities who have the lived experiences and realities to speak to specific issues and concerns regarding their lives here in Peel. I will now hand the webinar back over to Dawn, who will speak to the Young Black Women's Project.
Okay, thank you, Matt. So the Young Black Women's Project, it was developed by staff here at our organization at Peel HIV/AIDS Network while they were working with peers and volunteers in the community who identified as African Caribbean Black women, or ACB women, in Peel. The program, it seeks to engage and connect young Black women in Peel through community dialogues and opportunities to build their social capital. The program focuses on centering the lived experience and knowledge of racialized women who face the intersections of sexism, racism, and colonization. So I have the third question for you. So true or false? According to 2006 national survey data, 37% of new HIV diagnoses in Canada were among ACB or African Caribbean Black women. Okay, thank you everyone for your vote. The answer, okay, thank you. The answer is true. So African Caribbean Black women, as well as women who are Indigenous or Aboriginal, are also, there's 36% of new HIV diagnoses in Canada are among Aboriginal women as well. This means that over 70% of women living with HIV in Canada are racialized or from racialized communities. It's important to also recognize that women ages 30 to 39 have the highest rates of HIV infection rates in Canada. So what people are seeing right now is a slide from Katie, and it's an infographic. And just take a look at it and see, and to see more, just go to Katie, that's katie.ca for more information.
Hi everyone, this is Sarah speaking now. I believe that there's a case vignette that's been attached to this slide, so if folks have had a chance to look at that, that's great. We'll give you 3 minutes to just review the case study, and then we'll get started.
And just before we jump onto the case vignette, we'd like to share that all of these community-based interventions are delivered at no cost to the participants, thanks to our funding. Some of you folks may have recognized the fact that we put 2S in front of our acronym, so Two-Spirit and LGBTQ plus communities. That's also a part of the organization's push towards Truth and Reconciliation Commission's calls to action and putting Two-Spirit folks at the center and at the front. So we'll give you folks, again, 3 minutes to sort of dwell into the case, and we'll jump into the discussion questions in a few minutes.
Okay, everyone, welcome back. I hope you've had a couple minutes to review the case study. So to start off, we're just going to start with a discussion question. So based on this case, what factors may contribute to a decline in Shay, the client, accessing healthcare services moving forward? So we're just going to go over a chart here. Okay, we'll give you guys about a minute to come up with some questions or some comments based on that discussion question. Okay, so I'm just going to go over this this brief chart here. So we have a fishbone diagram here that kind of illustrates some of the issues that may contribute to Shay, the client, not accessing healthcare services moving forward. So some of the pieces might include acknowledgement. So the physician does not use the correct pronouns when referring to the client. And there's a lack of discussion around Shay's gender identity when they do come out to the physician, which may lead to the client feeling ignored or not acknowledged. There's also some power relations at play. So just a few of the ones that are inherent or obvious from the case study are that
There's a difference in race, racial identity. There's a difference between them in gender identity and as well as age. There may also be other factors at play, such as socioeconomic status, as Shay is a teenager and the physician is a person in their mid-50s and is a doctor. So they obviously are a little bit wealthier. And there's also social isolation at play here. So Shay speaks to some bullying that they're experiencing at school, having minimal to no support system, and having a lack of resources. And there's also some other factors here as well, like intersectional analysis, a lack of intersectional analysis, and the physical space that the physician is in. So the next chart here is kind of demonstrating what factors may increase the chance of STBBI infection rates. So it starts off with like the lack of pre and post test counseling around HIV, HCV, and STBBIs, a lack of awareness of queer and trans social determinants of health, and a lack of mental health supports, which may overall contribute to the client or patient needs not being met. And then this might lead to poor mental health outcomes with experiences of stigma and discrimination, as well as the social isolation piece that we discussed in the previous slide. This may contribute to the client self-medicating with non-functional substance use or sharing drug equipment. They may make uninformed sexual behaviors or choices around sexual behaviors. So there's a lack of awareness of U equals U or access to PEP and PrEP or condoms. And the client or patient is then lost from healthcare system. They have a lack of self-esteem and confidence in navigating the healthcare system. And this may contribute to them not going back to their doctor and could contribute to a potential rise in STBBI infection rates.
We recognize that the slides are the charts may not be the most visible. We'll definitely share it with folks moving forward. So I'll move on to our next question, which is how can we integrate these community-based interventions and leading practices into primary healthcare practice? So we'll give you folks a chance to sort of just think about that, reflect on that, and then we'll share our perspectives before opening the floor up for your comments, because this is really a question that we as an agency have continued to work toward in terms of engaging with other stakeholders in terms of the HIV/AIDS sector. So we'll give you folks about a minute, and then we'll jump into what we see as a response to this. So how we sort of, so let me repeat the question. So what are potential strategies for the integration of some of these community-based interventions with primary care? So we'd like to take this opportunity to ask folks about how they think that these CBIs could be integrated with health service providers more closely. If you look at the diagram, we've sorted the following potential strategies under micro, meso, and macro levels of influence. Looking specifically at the micro levels of influence and reflecting on patients' first legislation and the action plan itself, there was a push to improve healthcare access, offer better coordinated care in the community, and inform folks more diligently around the resources they have access to. So if you think about the integration of these community-based interventions, it's about highlighting this as an opportunity to support the social determinants of health of these folks and they're in these communities, and recognizing that they have unique needs, which often means a multidisciplinary approach to patient-centered care. So at the micro level, it's ensuring healthcare providers support these community-based interventions and the need to be competent around relevant language. What we mean by relevant language is earlier when we talked a little bit around pronoun use and how folks identify. Specifically, even if you reflect on the case itself, there were multiple opportunities where healthcare providers can act as allies and support clients as they journey through our healthcare system. So in order to do this, we also see a need to have a bit of a systemic push towards recognizing the identities of these communities. Therefore, at a meso level, we need to talk about systems and structures that support the health of these communities. So a couple of questions to sort of reflect on is the education curriculum that healthcare providers participate in reflective of these diverse communities and their needs? Are we talking about PrEP? Are we talking about PEP? So PrEP is pre-exposure prophylaxis, and PEP is post-exposure prophylaxis. Are we talking about U equals U, which is undetectable equals untransmittable? And are we talking about these with the same consistent language? Is there an opportunity to influence tools such as health links and coordinated care plans to support folks influenced by Syndemics? So even if you look at the health equity impact assessment tools, are folks familiar with the 2S LGBTQ plus supplements, and are folks using it? Are there opportunities to more closely collaborate with AIDS service organizations such as ourselves? So then when we take a step back and we look at sort of the micro level of influence, there's an opportunity to look at patients and patient, family, and public advisory committees and the reflection of 2S LGBTQ plus folks in these circles. And what does that representation look like? Are these homogeneous groups with one or two queer and trans folks whose voices get sidelined when these conversations around healthcare take place? We talk about evidence-informed care, but there's often a lag between evidence-informed practice and the integration of these practices into care. There's always this consistent need talking about data. But if we even look at the systems in place to collect data, when do we actually ask? Or historically, we haven't necessarily been asking about folks who identify as trans, specifically in our healthcare system. So, and again, where does the evidence lie around pieces such as U equals U and PrEP? And is there a consistent knowledge of these HIV prevention strategies across the board? And this means that we need leadership at higher up levels around all of these pieces. And over the years, there's also been a shift from the community caring for folks living with HIV to the privatization of HIV care, which means that it's important to recognize the shift in power dynamics. And what does this specifically mean? We recently came across an intervention that in New York, which talked about an HIV doula and taking back that power in terms of supporting folks in the community living with HIV/AIDS. So these are a couple of things that we sort of reflected on and thought about, and we would be very much interested to know what you folks think around the integration of some of these community-based interventions into primary care. So brilliant. We're getting some comments from the chat box as well. So talking about primary care offices developing leads who mentor and share information within their practice groups. Yes, that's there's definitely a leadership role. Even if you take a look at the primary care leads with the local health integration networks and how that information is sort of shared with their resource tools. Another comment talking about the need for top-down approaches to some degree. Yes, there needs to be a certain degree of structural supports in order for organizations and communities to work together towards this mutual goal of ending stigma and discrimination. So if there aren't any additional comments for this question or the previous question, we can just open up the floor for questions and answers. And Rachel, I believe you'll take the lead on that piece, or?
Yeah, thank you to our presenters for that very informative presentation. So we have about just over 10 minutes for questions and answers. So I would just invite you to once again use the chat function to ask your questions to our presenters, and then we'll hand it over to them. I did have a few questions in relation to sharing the slides, so I will share those with everyone on the call today via email after the presentation. So we'll just give folks a few minutes here to type their questions into the Q&A, and then we'll hand it back over to our presenters.
Great, thank you.
So it looks like we have a few comments, so I'll let our presenters address those. There's also one question from Anita. I agree that healthcare providers need more inclusive training as part of their curriculum. So I think the question to our presenters is, do you have examples of such curriculum from other jurisdictions?
Okay, hi, this is Dawn. Because most of our healthcare is provincially driven, I know that there's some training in Vancouver and Alberta, but not for all of the the whole country. We're not aware of all of them, but some will have and some will not. Here in Ontario and in Peel, we do, our hope is to provide more training to primary care physician. At one time we had training that we were providing for new docs. And we had a group of doctors that were training with a local university that came in, got the training, and we brought it to their colleagues. And we do try and provide trainings to family care physician in our community.
So I think sort of to piggyback on that response, I think aid service organizations have traditionally been the folks to lead this kind of education around HIV prevention strategies, as well as pieces pertaining, as well as educational campaigns pertaining to queer and trans health. So I would assume that ASOs or aid service organizations, with the exception of Saskatchewan, those provinces or organizations and institutions that are of similar mandates would be the folks that are taking on this piece. And Richard, thank you for your comment as well. Be helpful to provide more information and awareness in curricula for education of healthcare providers. Yeah.
And this is Rachel from CPHA. If I could just add to the question around curricula, CPHA has been working on developing the content for training for health and social service providers. And so we've now developed the content for 4 different workshops that really focus on reducing stigma related to sexually transmitted and bloodborne infections. And so we're now working with different community organizations. Yoshi, you mentioned ASOs across the country, working with those organizations to work with them to adapt and actually facilitate training in their own communities. And so if that's of interest to anyone, you can connect with me. I'll once again put my email address in the chat function there, just if you're interested in looking at some of our curriculum. It's intended for a broad range of frontline health and social service providers, but it could also be integrated into different programs for various health and social service providers.
I think just to touch, just to sort of add to that as well, I think, Rachel, when you said working with these communities and with these agencies is important, because even if you look at, you do need to be mindful of the communities that you serve. So just noting that for Peel, we serve a huge newcomer population, and folks here won't necessarily always use the same language. So even if you talk about programs for gay, bi, queer men, there are communities within Peel that don't necessarily resonate with those same labels. So even if you talk about African Caribbean Black populations, and the language they are familiar with and the language they are comfortable with is same gender loving men or women. So I think it's important to just sort of be reflective of the communities that you serve, because the language and the language is very much different.
So I don't see any other questions at this time. So once again, thank you to our presenters for that very informative presentation. Their names are there, and you can also connect with them. Looks like they've provided some links to their social media networks, and you can also connect with me directly if you'd like their information. So I just want to invite you to register for CPHA's next webinar. That's a part of our webinar series on STBBIs and the reduction of stigma. So the next webinar we're holding is Reducing Stigma in Sexual and Reproductive Health Care for Indigenous Women, Girls, and Gender Diverse People. And so this will be presented by the Native Women's Association of Canada, and it will be held on February 5th from 1 to 2 Eastern Time. So you can register for that using the link on your screen. And then before closing, I'd just like to ask everyone on the line to please take a minute to fill out CPHA's anonymous evaluation survey. So your feedback will really just help us improve future webinars, and we'll certainly share that information with our presenters. So the survey should open once you exit the webinar platform, or you can use the link on your screen there. And then, as I mentioned, the webinar recording will be made available on CPHA's YouTube channel. We anticipate that it'll be up in the next roughly 2 weeks. And then you can also find out more information about CPHA's webinar series, as well as some of CPHA's resources focused on the reduction of STBBI-related stigma at our website, or you can contact me directly. So the link to all of our webinar series, as well as the information, is the third link on the slide there. So with that, thanks again to our presenters, and thank you to everyone on the line for sharing your thoughts with us and engaging in this very important information. Have a great day.
Thanks, folks.
Thank you.
Bye-bye.